Question 1. A nurse is caring for a client with acute respiratory distress syndrome, ARDS, who is on mechanical ventilation with high PEEP settings. The nurse notes a sudden drop in blood pressure, muffled heart sounds, and jugular vein distension. Which immediate action is most appropriate? A. Administer a rapid intravenous fluid bolus. B. Increase the ventilator rate to improve gas exchange. C. Prepare for emergent pericardiocentesis. D. Notify the healthcare provider and prepare for needle decompression. Answer: D. Notify the healthcare provider and prepare for needle decompression. The concept tested here is recognizing the signs of a tension pneumothorax, a life-threatening complication, especially in clients with ARDS on high PEEP, positive and expiratory pressure. The keywords sudden drop in blood pressure, muffled heart sounds, and jugular vein distension are classic indicators of obstructive shock, specifically tension pneumothorax or cardiac tamponade, but in the context of high PEEP, tension pneumothorax is highly suspected due to barotrauma. A tension pneumothorax occurs when air enters the pleural space during inspiration but cannot exit, leading to pressure buildup that compresses the heart and great vessels, causing hemodynamic instability. Notifying the provider and preparing for needle decompression to relieve the trapped air is the most critical immediate action. Remember, in a client with ARDS on mechanical ventilation, always consider barotrauma and its complications like tension pneumothorax when acute hemodynamic deterioration occurs. Question 2. A client with chronic obstructive pulmonary disease, COPD, is admitted with acute exacerbation. The nurse notes a respiratory rate of 28 breaths/min, SpO2 of 88% on room air, and significant accessory muscle use. Arterial blood gas, ABG, results are pH 7.28, PaCO 268 mm of mercury, PaO 255 mm of mercury, HCO 328 milliequivalent/L. Which of the following oxygen delivery devices is most appropriate for this client initially? A. Nasal cannula at 6 liters per minute. B. Non-rebreather mask at 10 liters per minute. C. Venturi mask at 28% FiO2. D. Simple face mask at 8 liters per minute. Answer: C. Venturi mask at 28% FiO2. This question evaluates the nurse's understanding of oxygen therapy for clients with COPD, focusing on controlled oxygen delivery. The keywords COPD and acute exacerbation are crucial, as clients with chronic hypercapnia, high PaCO2 as seen in the ABG, rely on hypoxic drive for breathing. A Venturi mask at a low, precise FiO2, like 28%, delivers controlled oxygen, preventing suppression of the hypoxic drive and worsening hypercapnia. Administering high-flow oxygen, as with a non-rebreather or high-liter nasal cannula, can lead to respiratory depression in these clients. A practical example is using the Venturi mask-specific adapters to ensure the exact oxygen concentration is delivered, which is vital for COPD patients. Always remember, for clients with COPD, the goal is controlled, low-dose oxygen to improve hypoxemia without causing hypercapnic respiratory failure. Question 3. A client with a new tracheostomy tube requires suctioning. The nurse notes thick, tenacious secretions. Which intervention is most appropriate to facilitate removal of these secretions? A. Increase suction pressure to maximum. B. Instill 5 milliliters of normal saline into the tracheostomy tube prior to suctioning. C. Hyperoxygenate the client with 100% oxygen for 30 to 60 seconds before suctioning. D. Increase the frequency of suctioning to every 15 minutes. Answer: C. Hyperoxygenate the client with 100% oxygen for 30 to 60 seconds before suctioning. The core concept here is safe and effective tracheostomy suctioning, especially when dealing with thick secretions. The keyword thick, tenacious secretions indicates a potential for airway obstruction and difficulty with removal. Hyperoxygenating the client with 100% oxygen for 30 to 60 seconds prior to suctioning is critical to prevent hypoxemia during the procedure, which is exacerbated by difficulty removing secretions. Instilling normal saline is generally discouraged as it can introduce bacteria, wash secretions deeper, and traumatize the mucosa. While increasing suction pressure might seem helpful, it increases the risk of mucosal damage. Frequent suctioning should be based on client need, not just secretion consistency. Always prioritize oxygenation and client safety when performing suctioning. Question 4. A nurse is preparing to auscultate the lungs of a client suspected of having pneumonia. Which adventitious breath sound is most characteristic of bacterial pneumonia, typically heard over the affected lobe? A. Inspiratory wheezes. B. Rhonchi. C. Fine crackles. D. Pleural friction rub. Answer: C. Fine crackles. This question tests the nurse's ability to differentiate adventitious breath sounds and relate them to specific respiratory conditions, specifically pneumonia. The keywords pneumonia and characteristic direct the focus to the primary lung sound associated with alveolar inflammation and fluid. Fine crackles, often described as popping or crackling sounds, occur when air opens deflated alveoli or passes through fluid in the alveoli, which is exactly what happens in pneumonia due to inflammatory exudates. Inspiratory wheezes indicate narrowed airways, rhonchi suggests secretions in larger airways that may clear with coughing, and a pleural friction rub indicates inflamed pleura. Always associate fine crackles with conditions like pneumonia and pulmonary edema where alveoli are involved. Question 5. A client with a chest tube inserted for a pneumothorax suddenly reports severe, sharp chest pain and dyspnea. The nurse assesses crepitus around the insertion site and absent breath sounds on the affected side. What is the most appropriate initial nursing action? A. Clamp the chest tube immediately. B. Reposition the client to the unaffected side. C. Assess for chest tube dislodgement or air leak. D. Increase oxygen delivery via nasal cannula. Answer: C. Assess for chest tube dislodgement or air leak. This question addresses the critical skill of troubleshooting chest tube complications, specifically signs of an air leak or dislodgement leading to recurring pneumothorax. The keywords suddenly reports severe, sharp chest pain and dyspnea, crepitus around the insertion site, and absent breath sounds on the affected side strongly suggest a new or worsening pneumothorax, likely due to a malfunctioning chest tube system. Clamping the chest tube without a specific order can worsen a pneumothorax, and repositioning or just increasing oxygen doesn't address the root cause. The priority is to assess the system for a leak or dislodgement and then intervene based on findings, such as applying a sterile occlusive dressing if dislodged or checking connections for leaks. Remember, always troubleshoot the chest tube system first when a client's respiratory status acutely declines. Question 6. A nurse is assessing a client with pulmonary embolism, PE. Which arterial blood gas, ABG, finding would the nurse most likely expect initially in a client experiencing an acute PE? A. Respiratory acidosis. B. Metabolic acidosis. C. Respiratory alkalosis. D. Compensated metabolic acidosis. Answer: C. Respiratory alkalosis. This question assesses the nurse's understanding of the initial physiological response to an acute pulmonary embolism and its impact on ABG values. The keyword initially is important, as the body's immediate response to hypoxia and anxiety due to the PE is hyperventilation. Hyperventilation blows off carbon dioxide, CO2, leading to a decrease in PaCO2, which results in respiratory alkalosis, high pH, low PaCO2. while metabolic acidosis can occur later due to lactic acid buildup from tissue hypoxia, and respiratory acidosis if respiratory failure ensues. The immediate, most common ABG finding is respiratory alkalosis. Consider that the body tries to compensate for the lack of oxygen by breathing faster and deeper. Question 7. A client with a history of asthma is admitted with status asthmaticus. Despite receiving nebulized bronchodilators and systemic corticosteroids, the client's condition is worsening, with absent breath sounds in lung fields. What is the nurse's priority action? A. Prepare for intubation and mechanical ventilation. B. Administer another dose of inhaled bronchodilators. C. Obtain an arterial blood gas, ABG, reading. D. Encourage the client to cough and deep breathe. Answer: A. Prepare for intubation and mechanical ventilation. This question tests the nurse's ability to recognize severe, life-threatening asthma exacerbation and prioritize interventions. The keywords status asthmaticus, worsening, and absent breath sounds are critical clues. Absent breath sounds in an asthmatic client signify severely diminished airflow due to extreme bronchospasm and mucus plugging, indicating impending respiratory failure. A silent chest is an ominous sign. At this stage, further bronchodilators are unlikely to be effective, and ABGs, while important, are not the immediate priority over airway management. The immediate priority is to secure the airway via intubation and initiate mechanical ventilation to support respiration and allow for aggressive treatment. Question 8. A nurse is educating a client with newly diagnosed idiopathic pulmonary fibrosis, IPF, about disease progression. Which statement by the client indicates a need for further teaching? A. I will need to avoid respiratory infections by getting my flu and pneumonia vaccines. B. My lung damage might improve with medication and pulmonary rehabilitation. C. I should report any increased shortness of breath or dry cough to my doctor. D. Oxygen therapy will help me manage my breathing as the disease progresses. Answer: B. My lung damage might improve with medication and pulmonary rehabilitation. This question assesses the nurse's understanding of the irreversible nature of idiopathic pulmonary fibrosis, IPF. The keyword idiopathic pulmonary fibrosis is key, as it signifies a progressive, irreversible scarring of the lungs. The statement, my lung damage might improve with medication and pulmonary rehabilitation, indicates a misunderstanding. While medications can slow progression and pulmonary rehabilitation can improve quality of life and exercise tolerance, they do not reverse or improve the existing lung damage. The other options are correct management strategies for IPF. It's important to educate clients that IPF causes permanent scarring, and treatment focuses on managing symptoms and slowing disease progression, not reversing damage. Question 9. A client with a history of heavy smoking and chronic bronchitis is scheduled for discharge. Which instruction is most important for the nurse to include in the discharge teaching plan to prevent future exacerbations? A. You should get a flu vaccine every year. B. Limit your daily fluid intake to 1.5 liters. C. Use your inhaled bronchodilators only when you feel short of breath. D. Avoid all forms of physical activity to conserve energy. Answer: A. You should get a flu vaccine every year. This question tests the nurse's understanding of crucial preventative measures for clients with chronic bronchitis and COPD. The keywords chronic bronchitis and prevent future exacerbations highlight the importance of avoiding triggers, especially infections. Respiratory infections are a leading cause of acute exacerbations in COPD. Therefore, advising annual flu vaccines and pneumonia vaccines, as appropriate, is paramount. Limiting fluids can make secretions thicker. Using bronchodilators only PRN might not be optimal for maintenance, and avoiding all physical activity is detrimental to pulmonary rehabilitation and overall health. Emphasize vaccination as a key defense strategy against respiratory illness in vulnerable clients. Question 10. A nurse is assessing a client receiving continuous positive airway pressure, CPAP, via nasal mask for obstructive sleep apnea. The client reports dry mouth and nasal congestion. Which intervention should the nurse recommend? A. Discontinue CPAP use for a few nights. B. Increase the CPAP pressure setting. C. Use a humidifier with the CPAP machine. D. Switch to an oxygen mask for sleep. Answer: C. Use a humidifier with the CPAP machine. This question tests the nurse's knowledge of common side effects of CPAP therapy and appropriate interventions. The keywords dry mouth and nasal congestion are common complaints directly related to the continuous airflow from CPAP without adequate humidification. Adding a humidifier to the CPAP machine is the standard and most effective intervention to address these symptoms, as it adds moisture to the pressurized air. Discontinuing CPAP can worsen sleep apnea, increasing pressure won't help with dryness, and switching to an oxygen mask doesn't treat sleep apnea and isn't the primary solution for dryness. Always advise clients to use heated humidification with CPAP to improve comfort and adherence. Question 11. A client with newly diagnosed tuberculosis, TB, asks the nurse, "When can I stop taking my medications?" What is the most appropriate response by the nurse? A. You can stop taking them when your symptoms improve. B. You must complete the full course of treatment, typically 6 to 9 months, even if you feel better. C. You can stop after 2 consecutive negative sputum cultures. D. You can stop once your chest X-ray shows no signs of active disease. Answer: B. You must complete the full course of treatment, typically 6 to 9 months, even if you feel better. This question assesses the nurse's knowledge of client education for tuberculosis treatment adherence. The keyword newly diagnosed tuberculosis, TB, and the client's question about stopping medications highlight the critical importance of treatment compliance. TB treatment requires a prolonged course, typically 6 to 9 months, to eradicate the bacteria and prevent drug resistance and relapse. Stopping treatment early, even if symptoms improve or cultures become negative, is a common reason for treatment failure and the development of multi-drug-resistant TB. Emphasize that full adherence is non-negotiable for successful treatment and public health safety. Question 12. A client is receiving mechanical ventilation with a synchronized intermittent mandatory ventilation, SIMV, mode. The nurse observes the client's respiratory rate is 24 breaths/min, while the ventilator setting is 12 breaths/min. What does this assessment finding indicate? A. The client is fighting the ventilator. B. The ventilator settings are too high for the client's needs. C. The client is initiating spontaneous breaths. D. The client is developing respiratory acidosis. Answer: C. The client is initiating spontaneous breaths. This question tests understanding of different mechanical ventilation modes, specifically SIMV. The keywords SIMV mode and client's respiratory rate is 24 breaths/min, while the ventilator setting is 12 breaths/min are crucial. SIMV allows the client to take spontaneous breaths between the ventilator's mandatory breaths, while still ensuring a minimum number of breaths if the client doesn't spontaneously breathe enough. The difference between the client's observed rate and the set rate indicates the client is taking additional, spontaneous breaths, which is often a positive sign of improving respiratory effort. This mode is often used for weaning from mechanical ventilation. Question 13. A nurse is caring for a client with a chest tube inserted for a hemothorax. The nurse notes continuous bubbling in the water seal chamber. What is the nurse's priority action? A. Document the finding as normal. B. Check the tubing for kinks or obstructions. C. Assess the client for signs of respiratory distress. D. Systematically check the entire system for an air leak. Answer: D. Systematically check the entire system for an air leak. This question assesses the nurse's ability to interpret chest tube drainage system findings and prioritize actions. The keywords chest tube inserted for a hemothorax and continuous bubbling in the water seal chamber are the key. For a hemothorax, continuous bubbling indicates an air leak, which is not expected unless there's an ongoing pneumothorax or the air leak is new/worsening. Normal findings for a hemothorax would be tidling in the water seal and serosanguinous drainage, not continuous bubbling. Therefore, the priority is to systematically check the entire system, starting from the client insertion site to the drainage unit, to locate and resolve the source of the air leak. Question 14. A nurse is assessing a client with severe emphysema. Which physical assessment finding would the nurse anticipate? A. Tracheal deviation towards the affected lung. B. Moist crackles throughout all lung fields. C. Hyperresonance on percussion of the chest. D. Increased tactile fremitus. Answer: C. Hyperresonance on percussion of the chest. This question tests the nurse's knowledge of classic assessment findings in clients with severe emphysema. The keyword emphysema is crucial, as it leads to air trapping and hyperinflation of the lungs. Hyperresonance on percussion is the hallmark sound of an overinflated, air-filled lung, like a drum. Tracheal deviation is usually seen in tension pneumothorax. Moist crackles are more associated with fluid in the lungs, example pneumonia, heart failure. Increased tactile fremitus, vibrations felt on the chest wall, is associated with consolidation, such as in pneumonia. Think of the emphysematous lung as an inflated balloon, leading to a booming sound when tapped. Question 15. A client with pneumonia has a PaO2 of 58 mm of mercury on 4 liters per minute nasal cannula. The nurse notes increased work of breathing and confusion. Which is the most appropriate nursing intervention? A. Continue with 4 liters per minute nasal cannula and reassess in 30 minutes. B. Titrate oxygen up to 6 liters per minute via nasal cannula. C. Anticipate a change to a non-rebreather mask or high-flow nasal cannula. D. Encourage deep breathing exercises to improve oxygenation. Answer: C. Anticipate a change to a non-rebreather mask or high-flow nasal cannula. This question assesses the nurse's ability to recognize signs of worsening hypoxemia and escalate oxygen therapy appropriately. The keywords PaO2 of 58 mm of mercury, which is low, increased work of breathing, and confusion, a sign of hypoxemia affecting the brain, indicate that the current oxygen delivery is insufficient. While increasing the nasal cannula to 6 liters per minute might help slightly, a PaO2 of 58 mm of mercury with symptoms of increased work of breathing often warrants a higher flow and concentration of oxygen delivered by a non-rebreather mask or high-flow nasal cannula to rapidly improve oxygenation. Deep breathing exercises are helpful but not sufficient for acute, symptomatic hypoxemia. The nurse needs to anticipate a more aggressive oxygen delivery method to prevent further deterioration. Question 16. A nurse is teaching a client about pursed lip breathing. Which instruction is most important for the nurse to emphasize? A. Inhale quickly through your nose, then exhale slowly through pursed lips. B. Exhale forcefully through your mouth, then quickly inhale through your nose. C. Inhale slowly through your nose for 2 counts, then exhale slowly through pursed lips for 4 counts. D. Inhale and exhale quickly through pursed lips to clear your airways. Answer: C. Inhale slowly through your nose for 2 counts, then exhale slowly through pursed lips for 4 counts. This question evaluates the nurse's understanding of the correct technique for pursed lip breathing, a vital technique for clients with obstructive lung diseases. The concept is to prolong exhalation and prevent air trapping. The instruction, inhale slowly through your nose for 2 counts, then exhale slowly through pursed lips for 4 counts, precisely describes the technique, emphasizing a slower, prolonged exhalation phase, longer than inhalation, that helps to keep the airways open during exhalation, reducing air trapping and improving gas exchange. This controlled breathing reduces dyspnea, particularly in clients with COPD. Question 17. A nurse is monitoring a client with acute respiratory failure who is receiving mechanical ventilation. The high-pressure alarm frequently sounds. What is the most likely cause of this alarm? A. Client disconnection from the ventilator. B. Excessive secretions in the airway. C. A leak in the ventilator circuit. D. Client experiencing respiratory arrest. Answer: B. Excessive secretions in the airway. This question tests the nurse's ability to interpret ventilator alarms and identify their common causes. The keyword high-pressure alarm signifies an obstruction or increased resistance to airflow within the ventilator circuit or the client's airway. Excessive secretions in the airway are a very common cause, as they increase the pressure needed to deliver a breath. Other common causes include bronchospasm, biting the endotracheal tube, coughing, or kinks in the tubing. Disconnection or a leak would trigger a low-pressure alarm. Respiratory arrest would likely cause a low-pressure or apnea alarm. Always check the client first when alarms sound, starting with their airway and then the tubing. Question 18. A client is admitted with suspected community-acquired pneumonia. Which diagnostic test result, if present, would most strongly support a diagnosis of bacterial pneumonia? A. Elevated white blood cell, WBC, count with a shift to the left. B. Decreased procalcitonin levels. C. Presence of viral antibodies in serum. D. Normal C-reactive protein, CRP, level. Answer: A. Elevated white blood cell, WBC, count with a shift to the left. This question assesses the nurse's understanding of diagnostic indicators for bacterial infections, specifically pneumonia. The keywords bacterial pneumonia are crucial. An elevated white blood cell, WBC, count with a shift to the left indicates an increase in immature neutrophils, BANs, which is a classic sign of an acute bacterial infection. Decreased procalcitonin levels and normal CRP levels would typically suggest a non-bacterial cause or absence of significant inflammation. Viral antibodies indicate a viral infection. Remember, a shift to the left points directly to your body fighting off a bacterial invader. Question 19. A nurse is caring for a client with cystic fibrosis, CF, admitted with a pulmonary exacerbation. The client is receiving chest physiotherapy, CPT, and nebulized Dornase alpha. Which of the following is the primary goal of these interventions? A. To reduce lung inflammation. B. To improve ventilation perfusion matching. C. To thin and clear tenacious respiratory secretions. D. To prevent bacterial colonization. Answer: C. To thin and clear tenacious respiratory secretions. This question focuses on the primary therapeutic goals for cystic fibrosis exacerbations. The keywords cystic fibrosis, CF, pulmonary exacerbation, chest physiotherapy, CPT, and nebulized Dornase alpha are all directed toward managing the thick, sticky mucus characteristic of CF. CPT mechanically mobilizes secretions, and Dornase alpha is a mucolytic agent that thins pulmonary secretions. While these actions indirectly improve ventilation perfusion matching and reduce infection risk, their primary, direct goal is to facilitate the thinning and clearance of tenacious secretions. Always link therapies like CPT and mucolytics in CF to their direct impact on mucus. Question 20. A client with a long history of uncontrolled hypertension and dyslipidemia presents to the emergency department with sudden onset of severe shortness of breath, pleuritic chest pain, and hemoptysis. Which life-threatening condition should the nurse immediately suspect? A. Asthma exacerbation. B. Pneumonia. C. Pulmonary embolism. D. Acute myocardial infarction. Answer: C. Pulmonary embolism. This question tests the nurse's ability to recognize the classic symptom triad of pulmonary embolism, PE, in the context of relevant risk factors. The keywords sudden onset of severe shortness of breath, pleuritic chest pain, and hemoptysis are hallmark symptoms of PE. The client's history of uncontrolled hypertension and dyslipidemia are risk factors for cardiovascular disease, which can predispose to deep vein thrombosis, DVT, and subsequently PE. While the other conditions might share some symptoms, the specific constellation presented strongly points to PE. Remember, PE presents acutely and requires immediate intervention. Question 21. A nurse is monitoring a client who underwent a thoracentesis for a large pleural effusion. Which finding should the nurse report to the healthcare provider immediately? A. Serosanguineous drainage from the puncture site. B. Client reports mild pain at the insertion site. C. Decreased breath sounds on the affected side. D. Small amount of clear fluid noted in the dressing. Answer: C. Decreased breath sounds on the affected side. This question assesses the nurse's understanding of potential complications following a thoracentesis. The procedure involves removing fluid from the pleural space, and a serious complication is pneumothorax, collapsed lung. The keyword decreased breath sounds on the affected side post-thoracentesis is a strong indicator of a developing pneumothorax, which requires immediate medical attention. Mild pain and serosanguineous or clear fluid from the site are common and generally expected post-procedure. A significant change in breath sounds, however, points to a new and critical problem. Always prioritize assessing lung sounds diligently after any pleural procedure. Question 22. A client with sleep apnea has been prescribed continuous positive airway pressure, CPAP. The nurse is educating the client about the importance of adherence. Which statement best explains the rationale for using CPAP? A. It helps improve lung elasticity and reduce inflammation. B. It provides a continuous flow of oxygen to increase blood oxygen levels. C. It keeps your airway open during sleep, preventing episodes of breathing cessation. D. It trains your respiratory muscles to breathe more effectively at night. Answer: C. It keeps your airway open during sleep, preventing episodes of breathing cessation. This question evaluates the nurse's knowledge of the mechanism of action for CPAP in obstructive sleep apnea. The keyword CPAP is crucial. CPAP works by delivering a constant stream of positive air pressure into the airway, acting as a pneumatic splint to prevent the collapse of the upper airway structures during sleep, which is the cause of obstructive sleep apnea. It does not primarily improve lung elasticity, directly increase blood oxygen, though oxygenation improves as a result of open airways, or train respiratory muscles. The main purpose is to maintain an open airway. Question 23. A nurse is caring for a client with a new diagnosis of lung cancer who is experiencing severe dyspnea and fatigue. The client asks, "What's the best way to get through this?" Which nursing intervention addresses both the physical and emotional needs related to these symptoms? A. Administering a PRN opioid analgesic and suggesting palliative care consultation. B. Teaching energy conservation techniques and discussing spiritual support options. C. Encouraging participation in a daily exercise program and providing a list of support groups. D. Advocating for aggressive chemotherapy and ensuring adequate nutritional intake. Answer: B. Teaching energy conservation techniques and discussing spiritual support options. This question tests the nurse's ability to provide holistic, patient-centered care for a client with lung cancer, addressing both physical and emotional/spiritual needs. The keywords severe dyspnea and fatigue are common and debilitating symptoms of lung cancer, while best way to get through this indicates a need for comprehensive support. Teaching energy conservation techniques directly addresses fatigue and dyspnea by helping the client manage their physical limitations. Discussing spiritual support options addresses the emotional and existential distress that often accompanies a cancer diagnosis, providing comfort and coping strategies. While other options may be relevant, this choice provides the most direct and holistic approach to the stated client needs. Question 24. A client with chronic bronchitis reports increasing cough with copious, thick, yellow-green sputum, fever, and worsening dyspnea. The nurse anticipates an order for which of the following? A. Antihistamine and cough suppressant. B. Broad-spectrum antibiotics and corticosteroids. C. Loop diuretic and fluid restriction. D. Bronchodilator and inhaled corticosteroids only. Answer: B. Broad-spectrum antibiotics and corticosteroids. This question assesses the nurse's ability to recognize signs of an acute bacterial exacerbation of chronic bronchitis and anticipate appropriate pharmacological interventions. The keywords increasing cough with copious, thick, yellow-green sputum, fever, and worsening dyspnea are classic indicators of a bacterial infection complicating chronic bronchitis. Broad-spectrum antibiotics are necessary to target the presumed bacterial infection, and corticosteroids help reduce the airway inflammation and bronchospasm characteristic of exacerbations. Antihistamines and cough suppressants are generally avoided as they can thicken secretions, while diuretics are for fluid overload. Bronchodilators are likely already part of their regimen and won't solely address the infection and severe inflammation. Question 25. A client post-lobectomy for lung cancer develops subcutaneous emphysema around the incision site. The nurse understands this finding indicates which of the following? A. An expected postoperative complication. B. A rupture of the diaphragm. C. Air leaking into the subcutaneous tissue from the lung. D. Impending respiratory arrest. Answer: C. Air leaking into the subcutaneous tissue from the lung. This question tests the nurse's understanding of subcutaneous emphysema, a common but important finding after thoracic surgery. The keyword subcutaneous emphysema refers to the presence of air or gas in the subcutaneous layer of the skin. Following a lobectomy, this typically indicates an air leak from the lung, which is escaping into the pleural space and then dissecting into the tissues of the chest wall. While it can be an expected finding in small amounts post-op, a significant or worsening amount warrants further assessment. It is not a rupture of the diaphragm, nor does it immediately indicate impending respiratory arrest, though the underlying cause, lung air leak, can be serious. It results from air moving where it shouldn't be, creating a crackling sensation upon palpation.